Hello, everyone. So this is a presentation from Ethiopia about health campaign integration experience and the case of malaria and trachoma, which we normally call it MALTRA, integration in the Amhara region, northern Ethiopia. Next, please. So I should start by acknowledging the partners that were supporting this program. The first one was the Carter Center that was really providing the lion's share of the contribution for the MALTRA week, for the MALTRA project. And of course, as you can see here, Paul Emerson from the Carter Center Trachoma program, he was the director, he was part of it. And also you see another person from Ethiopia, Carter Center, and you see also somebody from Pfizer, who was then the vice president of Pfizer. So, and also Lions Club was supporting this program. So as you can see, there are the logos of the participating organizations, the Ministry of Health of Ethiopia, the Lions Club International, and Amhara Regional Health Bureau, Pfizer, and ITI were the prominent partners, of course, including the local communities that are also providing support. Next, please. So why integration? Why did we go into this kind of integrated project called MALTRA? First of all, it is the epidemiologic relevance. We conducted integrated survey, which you will see in the next slide, and then determined the overlaps, the geographic overlap of these two diseases and how important, how grave the problem was in that particular region. So one is epidemiological relevance. The second one is operational feasibility. We had to look for the funding, the logistics, the human resources to really implement this project. And also we looked into the community acceptance. Community, by community we mean to say all the Amhara regional people, district people, communities at the grassroots levels. And also we had to really secure political will of the federal government, the regional government, the partners and stakeholders in this project. Next, please. So all this was lined up for us to implement the trachoma program, the MALTRA project. As you can see, one of the most important driving factors or success factors for this project was we conducted the prevalence survey, determined the distribution of the disease all over the country, all over the region, and the results provided extensive baseline data to guide planning, implementation, and evaluation of the integrated malaria and trachoma program in the Amhara region. So this was the first big step that we conducted in the Amhara region sometime in 2007. Next, please. So again, securing high-level political and donor commitment was very crucial for the success of the MALTRA project. As you can see here, President Carter and the Carter Center at large, including Mrs. Carter, they were very instrumental in this process. And you can also see Dr. Tedros Adhanom, the then Minister of Health of Ethiopia, who really endorsed it or who was really behind this project at the national level, at the federal level. And also you see Lions Club International as a funder for the trachoma program and also the communities. And therefore the Carter Center was willing to provide 3 million long-lasting nets. And in fact, if I correctly remember, the Carter Center Board of Trustees has approved 37 million US dollars for this project for over a 5-year period. Next, please. So the objectives of the MALTRA project was just to scale up the trachoma and malaria interventions and then to also enhance the achievement of the health sector development program of the country and the Amhara regional states. Next, please. So What was at the heart of this MALTRA project? It's just the campaign effectiveness. We integrated the program for an effective delivery and established an effective delivery strategy and for a larger population at a cheaper price or cost, and at a lower cost, I can say, and with good quality or better quality, with good supervision and control mechanisms in place, and also reaching larger populations in a faster period of time. Next, please. So what was the strategy now to really achieve this kind of effectiveness, campaign effectiveness? We used what we call MALTRA weeks strategies. So we had 2 weeks per year, 1 week in May and April, May, and 1 week either in October or November. These times were chosen as peak malaria transmission season, and also for the trachoma treatment, the best times of the year. And we started the project in November, not October, in November 2008. And the project ended due to lack of resources after 12 campaign rounds in 2014. So it was up and running for 6 years. Next, please. So what were the focus areas of the MALTRA project? What interventions we were implementing? So we should be very cautious here. We are not simply promoting drug distribution or treatment. We were combining both preventive, promotive, and also therapeutic or treatment services. So hygiene education for face washing, personal hygiene, latrine promotion for environmental improvement, and also we were implementing mosquito net promotion. We had 3 million bed nets, long-lasting insecticide-treated bed nets. And when it comes to the MALTRA week, we were distributing Zitromax for trachoma, mass treatment, and also we were screening and treating malaria cases. So the case detection and treatment for malaria along with the mass drug administration. Next, please. So what were the project components? What were the project management aspects that were very critical for the MALTRA project? One was the planning and budgeting. These are cyclic tasks that we used to really work very critically for the success of the program. And then logistics and supply chain. We had to plan our logistics. Availability of quartan, of the drugs, the diagnostics, and whatever we need, and the vehicles, and whatever, and also training and capacity building of the teams that are implementing the MALTRA project. And also now for raising community awareness, communication, and social mobilization was very critical. And of course, for any project, we have to monitor it, we have to supervise it, and also we have to do annual, progress reports, and then midterm and end-term evaluations. Next, please. So, as I mentioned earlier, we had a series of project activities for this project. One is conducting consultative workshops. We did this very intensively at the start of the project to get the buy-ins from all involved stakeholders at all levels of the administration or the federal structure. And also we did community level in order to get the community buy-in. We had to do lots of social mobilization meetings using mass media like radio and TV, and also we had to go to schools and to get the buy-in from schools and teachers, from students. And so the school health clubs were also very instrumental in this project. And also we had to mobilize all community leaders. Mind you, this is a big region of nearly 20 million population, so it was a huge undertaking. So we had to mobilize all health facilities within the region, be it public or private, that were or NGO owned. So everybody was effectively mobilized. And also we had to train health extension workers and teams that are really distributing the medicine, the screening, and any kind of MALTRA week activity at the community level. We had to produce huge health education materials for the health and health education and community awareness. Next, please. So, how was the MALTRA project workflow? We can just divide it into 3. Before the campaign, what needs to be done? We had our guideline. We have our book, our guide, our manual produced for this campaign. So, in fact, here it's the malaria component is missing, but we are delivering both where we are promoting the safe strategy for trachoma and also key messages for malaria prevention and control. And during the campaign, we do this normally 1 month before the MALTRA week. During the campaign, which means during the 1 week period of the campaign, we conduct trachoma MDAs or mass drug administrations. We test and treat also malaria cases, and also we do inspect our health workers, our community health extension workers, inspect households, whether they have latrines, whether there are bed nets in the households, and also they deliver key preventive and health education messages. And after the campaign, we continue delivering the key messages. We just try to hammer as much as possible so that the communities would really understand what they need to do even after the campaign. And also we do compile our reports, and we do conduct review meetings to really assess the performance of the campaign. Next, please. So this is just one health extension worker with her assistant, carrying all her supplies for the MALTRA week, walking, this is the means of transport to the villages from the district health centers. Next, please. So what was the outcome of this campaign? As you can see, we have divided the region into 2, East Amhara and West Amhara. So for West Amhara has more population than East Amhara. So the West Amhara is about 10 million or more than 10 million population. And West Amhara is about 6 to 7 million population, about 7 million population. So there were some big cities excluded from this campaign, like Bahar Dar, Gondar, Dese, and the like. These were not part of, because this campaign was not relevant for those settings, urban settings, big cities and towns. So as you can see, we started with something like 5.3 million population during the first MALTRA week. And then we were just gradually scaling up. In West Amhara, for example, we went to 9.3 million and then close to 10 million during the 5th round of the MALTRA week. So this is the number of people reached and treated for trachoma and also screened for malaria. Maybe we'll see the malaria in the next slide. Next, please. And the coverage, as you can see, is also very high all the way through. It's about above 80%, the coverage for MDAs. And that was not a fake there was no any kind of mischief or whatever. So the project was very successful in detecting and treating malaria cases. Next, please. So this was a campaign expenditure. It was growing as the program was expanding. Next. So the cost per treatment, as you can see, was just 13 cents per person treated. This is a very good buy-in. I mean, this is a good best buy, so to speak. So a very cost-effective campaign. Next, please. So these are the research topics we identified. So what makes an integrated health campaigns effective and sustainable? Identifying health campaigns for integrated delivery, which programs, where and how, and also perhaps if there be a need, comparing cost effectiveness or effectiveness and efficiency of vertical and integrated healthcare delivery. Thank you very much for listening. That's all from me. Any questions? Welcome.